She had been a nurse for 31 years. Not 31 years in the same hospital. Not 31 years on the same floor. Nursing careers rarely hold that still. But 31 years of the same work, the work of being in a room with a person who is frightened or in pain or both, and attending to what they needed, and knowing the difference between what they said they needed and what they actually needed, and managing the gap between those two things with the specific skill that accumulates only through 31 years of practice. Her name was Gloria Renee Ashford. She was 56 years old. She was a charge nurse on the 3rd floor of Callaway Regional Medical Center, which served a district of about 80,000 people, and which had, over the 22 years Gloria had worked there, grown from a 2-wing county facility into a 6-floor regional hospital with a trauma center and a cardiac unit and a teaching affiliation with the State University's medical school. She had started at Callaway Regional at 34. Before that, she had spent 9 years at 2 other hospitals in the district. The community clinic on the east side, which had been her first job out of nursing school, and which had given her the specific education that you only get from a clinic that is perpetually understaffed and overextended, where the protocols are correct, but the resources to follow them are sometimes theoretical. And a hospital upstate, where she had spent 4 years in oncology, and had developed the particular patience and endurance that oncology demands and that no other specialty quite replicates. She had come to Callaway Regional for the 3rd floor medical unit, which the director at the time had described to her in the interview as difficult in the specific way that good work is difficult, not because the work itself was beyond competence, but because it required every day more than competence. It required the full attention of a person who had chosen this work rather than fallen into it. The director who had hired her was a woman named Margaret Song, who had run Callaway Regional's nursing division for 16 years, and who had, in that time, developed a reputation for identifying the nurses who would still be excellent at 60, the way others identified them at 30. Not by their scores or their credentials, but by the quality of their attention in the interview, which she had learned after 16 years, was the single most reliable predictor of the quality of their attention on the floor. She had asked Gloria in the interview to describe a situation where she had disagreed with a clinical decision made above her and what she had done about it. Gloria had described a situation from her oncology years 12 years earlier where she had believed a patient's pain management protocol was inadequate for his stage of treatment, and had documented her clinical observations, requested a review, and maintained that request through 3 separate discussions with the attending physician until the protocol was adjusted. Margaret had said, and the outcome. Gloria had said the protocol was adjusted. The patient's pain was managed appropriately for the last 6 weeks of his life. Margaret had said, "Why didn't you stop at the first refusal?" Gloria had said, "Because the patient was there and needed the correct care, and I was the person who could see that it wasn't happening. There wasn't an alternative that made sense." Margaret had said, and if the physician had refused a 4th time, Gloria had said, "I would have escalated to the medical director." Not as an adversarial action, as the next step in the process. Margaret had hired her that afternoon. She had chosen this work. Her mother, Adeline Ashford, had been a home health aide for 28 years in the county north of Callaway. She had worked for a small agency that placed aides with elderly and disabled clients in their homes, and she had done this work with the specific commitment of a person who understands that what they are providing is not just physical care, but the presence of someone who sees the person as a person rather than as a condition. Gloria had watched her mother work during school vacations when the agency would sometimes allow Adeline to bring her daughter on visits to clients who needed company as much as they needed care. She had watched her mother sit with a man of 87 who had no family and who had not had a real conversation in 3 weeks, and she had watched her mother make conversation with him. Real conversation, not the performed cheerfulness of someone checking boxes, but actual engagement with who the man was, and what he thought, and what he remembered, and what still mattered to him. She had watched this, and had known at 16 that the work her mother did was the kind of work she wanted to do. Not specifically home health aid work. She had a different vision of the scope, but the same essential action, being in the room with someone who needed you to see them. Her father, Raymond Ashford, was an electrician who had run his own small business for 40 years. He had taught her two things that she had carried into nursing: that the most important thing about doing a job was understanding the job completely before you started, because the mistakes that could not be fixed were the ones made before you understood what you were working on, and that the people who were best at technical work were the ones who could explain it in plain language to someone who knew nothing about it, because if you could not explain it simply, you did not yet understand it fully. She had applied both of these to nursing. She had chosen it at 24 when she was a year out of college with a degree in biology and a growing certainty that the thing she wanted to do in the world was not research, but presence, not to study people at a distance, but to be in the room with them. She had gone to nursing school with that clarity, and had held it through 31 years of the particular difficulty of the work, and had never in 31 years considered doing something else. The difficulty of this work was not a secret. She had known it at 24 and had chosen it anyway, not naively, but with the specific understanding of someone who has watched a parent do hard work for 28 years and knows what hard work looks like from the inside, and has decided that the hardness is not a reason to avoid the thing. The oncology years had been the hardest. 4 years of being present with patients who were dying, many of them younger than she expected, some of them younger than she, was all of them navigating the specific terrain of a life being cut short with varying degrees of grace and fear and anger and hope. She had been present for all of it. She had done her job in all of it, and she had learned in those 4 years the thing that the oncology nurses she had respected most had all known: that being present for someone's hardest time was not a thing that diminished you. It was a thing that required something of you, yes, and took something from you, yes, but it also gave you in the specific and unreproducible way that hard, real work gives you a clarity about what mattered and a steadiness in the presence of difficulty that nothing else produced. She had carried this from oncology to Callaway Regional. She had carried it through 22 years of the third floor. She had carried it into a medication room at 7:18 on a Wednesday morning in March, where a man who did not know who she was had asked her to prove it. She had not proven it. She had not needed to prove it. She had simply been it. This was the thing she had tried to explain to the resident in the hallway after the code when he had asked how she stayed calm. She had said, "I'm not calm. I'm focused." But the fuller answer was this: after 31 years, there is no gap between who you are and what you do. The work and the person doing it have become the same thing. You do not have to maintain the identity under pressure, because the identity is the pressure management. You are the nurse. You were the nurse before you walked into that room. You continued being the nurse while a man who did not understand what he was looking at questioned your presence in your own workplace. You were the nurse 11 minutes later when Adeyeze Ose's heart stopped and needed someone who knew what to do. Nothing about what Cullen had said or done in that room had changed what she was. The proof had been in the room with her the whole time, in the badge on her chest, in the 22 years of institutional knowledge in her hands, in the 12 patients whose medications she was preparing when he walked in. The proof was the work. It had always been the work. She thought about this on the drive home that second morning, the day after Adeyeze Ose had been moved to step down and William Okafor had been well enough to joke with the resident during rounds, and Bernard Watts had filled 2 pages of the notepad with questions for the doctor, which meant he was engaged enough in his own treatment to want to understand it, which was a good sign. She thought about what it meant to carry 22 years in your hands, and have someone who had been in the building for 4 hours question whether those hands had the right to be where they were. She thought about this not with the anger she had felt in the moment that anger had been set down, not gone but set down, but with the cooler consideration of a person who has had a day to let the incident settle into its full shape. Its full shape was this: a man who did not know her had assumed on the basis of nothing more than not knowing her that she did not belong where she was. He had not asked. He had not introduced himself properly. He had not looked at the badge that was directly in front of him. He had simply decided before he walked through the door what he was going to find. This was the mechanism. This was the specific thing that produced situations like the one in the medication room at 7:18 on a Wednesday morning. Not malice, not policy, but assumption. The assumption that unfamiliarity means absence of right. The assumption that not knowing someone is evidence of something when it is evidence of nothing except not having been paying attention. 22 years of morning distributions and the badge on her chest, and the 12 patients waiting for their medications, and the code she would run 11 minutes later, all of it had been in the room with her. He had not seen any of it. She had continued her round. The day after and the day after that, she continued her round. She had a daughter, Kezia, who was 28, and who was in her second year of a family medicine residency at a hospital in the city. Gloria had not encouraged Kezia into medicine, but she had not discouraged her either. When Kezia had told her at 19 that she was thinking about medical school, Gloria had said, "It will take everything from you and give back something different. Make sure you want what it gives back." Kezia had said, "What does it give back?" Gloria had said, "You'll know when you get there." Gloria had meant it gives back the specific knowledge of having been in the room, of having done the thing that needed to be done, of being the person who knew what to do when no one else did. It gives back the particular form of clarity that comes from 31 years of working in a field where the margin for error is a human life, and from having operated for 31 years within that margin without going over it more than you have had to, and from understanding that every time you have not gone over it is the result of attention and preparation and the daily practice of care. What it takes from you is harder to explain. It takes the evenings when you cannot stop thinking about the patient in 3:07 and whether you read the vitals correctly. It takes the nights when a code does not go the way you needed it to go, and you lie in the dark, accounting for every decision you made and identifying what you would do differently. It takes the years, the cumulative weight of years of being needed in ways that do not stop when you leave the floor. She had told Kezia some of this over the years in pieces as Kezia had asked. She had not told her all of it because some of it was not transferable in words. Kezia would encounter it herself and would find her own accounting for it. Kezia was in her second year of residency. She knew now. Gloria had been at Callaway Regional for 22 years. She knew every floor. She knew every pharmacist, every lab technician, every orderly who had been there more than 2 years. She knew the emergency protocols, the way you know a thing you have run enough times that the running is in your body rather than your memory. She knew the medication rooms on the 3rd floor, the way she knew her own kitchen, every drawer, every shelf, the specific location of every item and the exact arrangement she had helped establish 6 years ago when the floor had been reorganized. She knew where everything was. She knew things about the 3rd floor that were not in any policy document. She knew that the medication room's top left cabinet had a shelf bracket that had been slightly loose for 8 months, and that if you placed anything heavier than a standard blister pack on the left side of that shelf, it shifted, and she had put in 3 work orders for it and had been waiting. She knew that the supply closet at the end of the east corridor had a sensor light that did not trigger reliably in cold weather, and that in February you needed to wave your arm twice to get it to come on, which patients and visitors often found alarming. She knew that the charge nursing station had a chair that looked like it was adjustable and was not, and that new staff spent their first few weeks trying to adjust it before they gave up and left it where it was. She knew all of this because she had been there for 22 years, and because she paid attention. 22 years had produced other knowledge. She had learned which attending physicians communicated clearly and which required follow-up to ensure orders had been understood. She had learned which patient families needed to be told information twice and which needed it in writing and which needed it in a room with no one else present. She had learned the specific pressure points of a medical floor, the ways that small errors accumulated into large ones when no one caught them at the small stage. And she had developed over 22 years an early warning sensitivity to those accumulations that operated below the level of conscious awareness, a feeling before she could identify why that something was off, that she needed to look more carefully, that the situation required more attention than the surface suggested. This sensitivity had saved lives. She did not count them. The ones she did not count were not counted because there was no moment you could point to, no code run, no crisis resolved, just the ordinary, unremarkable intervention that happened early enough that the crisis never arrived. These were invisible. This was fine. Invisible was the ideal outcome. On a Wednesday morning in March, she was at the medication room preparing the 7:30 distribution for the 12 patients on her half of the floor when the door opened behind her and a man she had not seen before walked in. He was wearing plain clothes. He was not in scrubs. He was not in the blue security uniform that Callaway Regional's contracted security firm used. He was in street clothes, and he was standing in the medication room, and he was looking at her. She said, "Can I help you?" He said, "I need to see your ID badge." She looked at him for a moment. She assessed him in the way she had learned to assess unfamiliar situations in a clinical environment, quickly without alarm, gathering the relevant information. He was young, early 30s, she thought. He was not in scrubs, not in a hospital uniform of any kind. He was in street clothes. He had not announced himself when he came through the door. He had not asked if it was all right to enter. He had simply entered and made a demand. She had been in situations before where a person had entered a clinical space without proper credentials, family members who had followed a wrong sign, visitors who had pushed through a restricted door, lost individuals looking for another floor. In each case, the correct response was the same: establish who the person was and whether they should be there before proceeding. She said, "Who are you?" He said, "I'm with hospital security. I need to see your ID badge." She said, "I'm the charge nurse on this floor. I've been here for 22 years. My badge is right here." She indicated the badge clipped to the left side of her chest, which was visible, which had been visible since he walked in, which displayed her photograph, her name, her title, her floor assignment, and the hospital's logo in full color. He looked at the badge. He looked at it in the way that someone looks at something they are not fully processing because they have already decided what they are going to do before they looked. He said, "I've received a report of unauthorized access to the medication room." She said, "I am authorized to access the medication room. I am the charge nurse on this floor." He said, "I'm going to need you to step out of the medication room while I verify that." She said, "I have a 7:30 distribution to complete. 12 patients." He said, "I understand, but I need you to step out." She said, "I am not going to step out of the medication room in the middle of preparing a distribution because someone filed an unverified report. If you have a concern, contact the nursing supervisor whose office is on this floor, or contact hospital administration. My name is Gloria Ashford. I have been the charge nurse on this floor for 16 years. You can verify that in 45 seconds. He said, "I need to ask you about the inventory in this room." She said, "The inventory in this room is my responsibility and is managed according to hospital protocol. I am asking you for the second time to identify yourself properly or to contact the nursing supervisor." He moved toward the medication shelves. She said, "Do not touch the medication inventory." He said, "I am conducting an investigation." She said, "You have not identified yourself, you have not produced credentials, and you are not in a hospital uniform. You are a stranger in a restricted area attempting to access controlled medication inventory. I am calling the nursing supervisor." She reached for the phone on the medication room wall. He moved between her and the phone. He said, "I am a plainclothes security officer. My name is Officer Dennis Cullen. I have been assigned to this investigation by Hospital Security Administration." She said, "Then Hospital Security Administration can verify that. Step away from the phone." He said, "Miss..." She said, "Nurse Ashford, step away from the phone." He did not move. She looked at him with the specific expression of a person who has been in rooms with frightened people for 31 years and has learned to distinguish between a person who is dangerous and a person who is wrong and has determined which of the two she is looking at. She said, "If you do not step away from the phone, I am going to call for assistance from this floor. There are 4 nurses on this floor right now who know who I am and know where I am supposed to be and who have not seen your credentials." She paused. She said, "Step away from the phone." He stepped away. She called the nursing supervisor. She looked at him with the specific expression of a person who has been in rooms with frightened people for 31 years and has learned to distinguish between a person who is dangerous and a person who is wrong, and has determined which of the two she is looking at. She was not afraid of him. She had been afraid in rooms before rooms where the situation was genuinely dangerous, where the potential for harm was real and immediate, where the correct response was the specific, controlled fear that sharpens attention without collapsing it. She had been in rooms like that. She knew what they felt like. This was not one of them. This was a room with a man who was wrong, who was proceeding with his wrongness in the particular way of someone who has not yet encountered anything to make him understand that he is wrong, and who was standing between her and a phone that she needed to reach. She said, "If you do not step away from the phone, I am going to call for assistance from this floor. There are 4 nurses on this floor right now who know who I am and know where I am supposed to be, and who have not seen your credentials." She paused. She said, "Step away from the phone." He stepped away. She called the nursing supervisor. Dennis Cullen was 31 years old. He had been with the hospital's contracted security firm for 2 years. He had been assigned that morning to a loss prevention investigation after a preliminary report had flagged an inventory discrepancy on the 3rd floor's medication log, a discrepancy that the pharmacy supervisor had identified the previous afternoon and had routed to security for follow-up. The discrepancy was 11 milliliters of a controlled medication hydromorphone, which the log showed as signed out by the charge nurse on the previous Wednesday's morning distribution, and which the pharmacy supervisor had flagged because the dosage documentation for one patient appeared inconsistent with the prescribed amount. The pharmacy supervisor was a man named Louis Tron, who had been managing the 3rd floor pharmacy supply for 11 years. He had flagged the discrepancy the previous afternoon at 3:30 in the routine end-of-day inventory review that was part of his standard practice. He had routed it to security as the protocol required, with a note that said, "This is likely a documentation error. Please verify through the charge nurse and the patient record before any further action." The note had said, "Verify through the charge nurse." It had not said, "Walk into the medication room during an active distribution." It was a paperwork question. It was the kind of discrepancy that in a well-run hospital gets resolved by pulling the original order, comparing it to the distribution log, and identifying whether the error was in the documentation or the dosage. It was the kind of question that had a specific resolution process. The specific resolution process did not involve a plainclothes officer walking into the medication room during a distribution and asking the charge nurse to step out. Cullen had not been told this, or had not understood it, or had understood it, but had made a decision, the same kind of decision that Rourke had made on 15th and Oak. The same kind of decision that happens when a person follows a procedure without pausing to consider whether the procedure is the right tool for the situation, and had walked up to the 3rd floor and into the medication room without first speaking to the nursing supervisor or the pharmacy supervisor, or anyone who might have told him that the woman preparing the 7:30 distribution was the charge nurse who had been doing so for 16 years. He had been assigned that morning by his shift supervisor, Karen Vogt, who had received the pharmacy referral and categorized it as a routine inventory follow-up. Karen had not specified a process because she had assumed that a 2-year officer knew that medication discrepancy investigations began with clinical consultation, not direct contact with clinical staff in restricted areas. She had assumed incorrectly. The knowledge was in the training materials. It had not been reinforced by practice. He had received a report. He had responded to it. The nursing supervisor, a man named Harold Price, who had been managing the 3rd floor's nursing staff for 8 years, arrived in the medication room 3 minutes after Gloria called. He was 47, precise, with the specific calm of a man who has managed a medical floor long enough to have encountered most varieties of crisis and has learned to begin by establishing the facts. He looked at Cullen. "He said, 'Who authorized you to be in this room?' Cullen said, 'I have an assignment from Security Administration.' Harold said, 'Do you have that authorization in writing?' Cullen did not. Harold said, 'This is Gloria Ashford. She is the charge nurse on this floor and has been for 16 years. She has authorized access to this room. You do not. I'm going to need you to leave this room now and go to the Security Administration office and wait.' Cullen said, 'I have an active investigation.' Harold said, 'You have an active investigation that you are currently conducting incorrectly.' The investigation process for a medication discrepancy begins with the pharmacy supervisor and the charge nurse, not with a plainclothes officer in a restricted clinical area. Step out." He stepped out. Harold turned to Gloria. He said, "Are you all right?" She said, "I have a 7:30 distribution." He said, "Yes, you do." He stayed while she completed it. Harold Price had been managing the third floor for 8 years. Before that, he had been a floor nurse for 14 years and a charge nurse for 5, which meant he understood the medication room from the inside, what it required, what it meant to be interrupted in it, what the weight of a 7:30 distribution actually was for a charge nurse responsible for 12 patients at the start of a morning. He had seen the exchange between Gloria and Cullen in its last 30 seconds from the doorway. He had been enough for him to understand the full shape of what had happened. He had dealt with Cullen directly and efficiently, but the thing he was now doing, being present at the door, not hovering, not managing simply, there was a different kind of work. He had seen nurses, over 22 years of working alongside them, absorb incidents that no one acknowledged and carry them forward into the rest of the shift without the absorption being visible in the work. The work continued. The quality held. You would not know, watching from outside, that anything had happened. But if you had been doing this work long enough, you knew that the invisible carrying had a cost, and that the cost was borne by the person who was carrying it, and that the least you could do, not the most, not a solution, but the least was to be present enough that the person knew the carrying had been witnessed. He was there at the door of the medication room for the 12 minutes it took Gloria to finish preparing the distribution. He did not speak during those 12 minutes. He was simply present in the way that a supervisor who understands what has happened is present after an incident, not hovering, not managing, but providing through the fact of being there the quiet acknowledgement that what had happened was not acceptable and that the person it happened to was not alone. She completed the distribution. She went to the first patient on her list. The patient was a 68-year-old man named Bernard Watts, who had been admitted 2 days earlier with complications from a procedure and who was on the recovery track but was not yet easy. He was in some pain. He was anxious in the specific way of a man who has been told he is doing well, but cannot quite make himself believe it because the feeling of well and the idea of well are not the same thing. Gloria had been managing his anxiety for 2 days. She had been managing it not with additional medication. The medication was calibrated and correct, but with the specific quality of attention that tells a person that they are being seen and that the person seeing them has done this before and is not afraid. She checked his vitals. Bernard Watts had been admitted 2 days ago and had been frightened from the moment he arrived, which was common. He was 68 and had spent his life managing things his own business. A small landscaping company he had run for 30 years. And before that, a crew at a grounds maintenance firm, and he did not manage well when things were happening to him rather than being managed by him. The loss of control that hospitalization imposed was a specific kind of distress for men like Bernard, and Gloria had learned over 31 years to meet it not by dismissing it or explaining it away, but by giving the man something to manage, some small domain where his attention could have an effect. She said, "How are you feeling this morning?" He said, "Like I'm supposed to say better." She said, "You don't have to say anything you're not feeling." He said, "My back." She said, "I'm going to adjust your position. Tell me when that helps." She adjusted his position. He said, "Yes, that's better." She said, "The doctor makes rounds at 9. I'm going to give you a notepad. If you think of questions between now and 9, write them down. It helps to have them ready." He said, "My wife usually does that." She said, "You can do it today." He looked at the notepad she put on the table beside him. He said, "All right." She said, "I'll be back before rounds." He said, "You're going to be here." She said, "I'm here until 3. He said, "Okay." She continued to the next patient. She had completed 8 of the 12 distributions when the overhead alarm went off. She was standing at the door of room 308, which was 4 doors from 3, 1-2 on the east corridor. She had just delivered the medication to the patient in 308, a 72-year-old woman named Cora, who was recovering from a fall and who had been in good spirits that morning, had asked about her son's visit. That afternoon had been alert and oriented in the specific way that told Gloria the morning was going well. The alarm told her the morning was about to go differently. The code blue was in room 312. Room 312 was 4 doors from where she was standing. She moved. She was in the doorway in 12 seconds. She had timed herself once, not as an exercise, but because a colleague had asked her during a training session how long it took her to get from the nursing station to the farthest room on the floor, and the answer had surprised them both 11 seconds running. 12 at a sustained fast walk that did not alarm patients in the rooms she passed. She did not run on the floor unless there was no alternative. Running alarmed patients. It communicated that something was wrong on the floor, which was true, but which was not information that most patients needed to have at the moment it was happening. She moved at the pace that got her there in 12 seconds, and did not announce to anyone who could see her in the corridor what she was moving toward. She had run Code Blues for 31 years. She had run them in 2 hospitals before Callaway, and she had run them at Callaway, and she had developed over those 31 years the specific capacity that code situations demand, the ability to hold many things in attention simultaneously, without losing track of any of them, to see the whole room and the individual patient at the same time, to coordinate a team that may include people who have worked together for years, and people who have never been in a code together, and who need in the first 30 seconds to understand who is leading and what the lead person needs from them. She knew the specific rhythm of the first 60 seconds, the arrival, the assessment, the assignment of roles, the coordination of the team that assembles in the first minute, and which, if the team is good, functions without being told who does what, because everyone already knows. She had run enough codes to know when a team was good and when it was not, and she knew arriving at 312 with 2 other nurses behind her and the crash cart in front of her, that the team she had was good. The patient was a 53-year-old woman named Adeyeze Osei, who had been admitted the previous day with a cardiac presentation that had been stabilizing and who was now not stabilizing. Gloria took the lead. She did not think about Dennis Cullen during the code. She did not think about the medication room or the 7:30 distribution or the question of who had filed the report. She thought about Adeyeze Osei 53 cardiac and what the next 3 minutes required. What the next 3 minutes required was everything she had. She gave it. The first attending physician arrived at 40 seconds. He was a cardiologist named Dr. Marcus Webb, 39. Who had been at Callaway Regional for 4 years, and who had worked with Gloria enough times to know that when Gloria was running a code, his role in the first minute was to take in what she had already established and build from there, rather than restart from the beginning. He arrived, absorbed what Gloria had done in the first 40 seconds, and took the lead on the medication decisions, while Gloria maintained the rhythm and the room. The second physician arrived at 2 minutes, an internal medicine resident, 27, whose name Gloria had learned 2 weeks ago and who she had not yet worked a code with. She had assessed him in the first 10 seconds of his arrival and had determined that he was capable and nervous, which was the correct state for a resident in a code, and she had given him a specific bounded task managing the IV access that would let him contribute without requiring him to navigate the larger picture until he had steadied himself. He steadied in about 90 seconds. The code ran for 11 minutes. At the end of 11 minutes, Adeyeze Osei had a pulse and a team of 3 nurses and 2 physicians around her bed and a treatment plan. And for the first time in 11 minutes, the presence of a heartbeat that was doing what heartbeats are supposed to do. The 11 minutes had contained the following: an initial assessment. A determination of the intervention required the administration of 2 medications, a cardioversion, a second cardioversion, a decision to try a 3rd medication before a 3rd cardioversion, and the 3rd cardioversion, which was the one that worked. Gloria had made 4 of those decisions. Dr. Webb had made 2. The resident had managed the IV access correctly throughout, and had noted at minute 7 a change in one of the readouts that prompted Gloria to adjust the timing of the 3rd intervention, which was the correct call and which Dr. Webb confirmed immediately when Gloria named it. At 11 minutes and 14 seconds, the monitor showed a rhythm. Dr. Webb said, "There we go." The resident released a breath he had not known he was holding. Gloria said, "Good work. Let's keep her." She left the room. She stood in the hallway for 45 seconds. She had learned sometime in her 2nd decade of nursing that there is a specific kind of exhaustion that follows a code that is not the same as physical tiredness, and that you cannot push through but must acknowledge in some small way before returning to the work. She stood in the hallway for 45 seconds and acknowledged it. The resident came out after her. He said, "Nurse Ashford." She turned. He said, "Thank you. I didn't know. I was trained, but I didn't know what to do with the training until you." She said, "You knew what to do. You just needed a few seconds to find it." He said, "How do you stay that calm?" She said, "I'm not calm. I'm focused. Those are different things." He looked at her. She said, "Calm is the absence of feeling. Focused is the management of it. You will never be calm in a code, but you can learn to be focused. It takes time." He nodded. She said, "You did well." She returned to the work. She had 4 distributions left. She completed them. She wrote her incident report regarding the medication room encounter at noon during her lunch break, sitting at the nursing station with a cup of coffee she did not drink because it went cold while she wrote. The report was 3 pages. It was factual and specific. It named Dennis Cullen, described his appearance, described his failure to provide credentials, described his movement to block access to the phone, and described the resolution with the nursing supervisor. It cited the hospital's policies on access to restricted clinical areas and on the investigation procedures for medication discrepancies, both of which Cullen had not followed. She submitted it to the nursing supervisor and to hospital administration. She had written incident reports before. The skill of writing them clearly, factually, without the inflation of anger or the compression of minimization, was a skill she had developed over 31 years, with the specific understanding that a report that could be argued with was less useful than a report that could not. She had been trained early in her career by a supervisor who had said, "If you write what you felt, it becomes about your feelings. If you write what happened, it becomes about what happened. Write what happened." She wrote what happened. She named every moment in sequence: the man at the door, the failure to produce credentials, the attempt to direct her out of the medication room during a distribution, the movement to the phone, her response to each action, Harold Price's arrival and resolution. She named the protocols that applied. She named the policies that had not been followed. She wrote it in 3 pages and did not use a single word that could not be verified by a third party who had been in the room. Harold Price had already submitted his own report. The hospital's patient safety officer, a woman named Dr. Constance Ferris, who had been in the role for 7 years, received both reports before 2 p.m. She had also received separately the results of the pharmacy supervisor's investigation into the original discrepancy, which had been resolved that morning. The 11-milliliter difference was a documentation error in the distribution log, not a dosage error, and had been corrected. The controlled medication had gone exactly where it was supposed to go. The investigation that had sent Dennis Cullen to the 3rd floor had been predicated on a paperwork error that no longer existed by the time he arrived. Dr. Constance Ferris had been the hospital's patient safety officer for 7 years. She had come to the role after 12 years as a practicing internist and 3 years as a department head, and she had taken it because she believed after 15 years of clinical and administrative medicine that the place where the most harm was preventable was not in the moment of treatment, but in the systems around the treatment, the protocols, the training, the oversight, the procedures that either caught errors before they became incidents or failed to catch them and allowed incidents to become crises. She had spent 7 years building those systems at Callaway Regional. She was not a dramatic person. She was a specific person. The committee meetings she ran were short, documented, and actionable. Every item on the agenda had an assigned owner and a due date before the meeting ended. She did not accept vague commitments. She did not accept action items that could not be verified. She had read Gloria's incident report and Harold's incident report and the pharmacy supervisor's resolution note and the security firm's initial response in the 2 hours between receiving them and convening the meeting. Dr. Ferris convened a meeting that afternoon with hospital administration, the contract security firm's director, and the nursing supervisor. She said a plainclothes security officer entered a restricted clinical area during an active medication distribution, failed to provide proper credentials, attempted to block a charge nurse's access to a phone, and conducted himself in a manner that was inconsistent with every protocol this hospital has for medication discrepancy investigations. This happened to one of the most experienced charge nurses on our staff during a shift on which she subsequently ran a code blue. I would like to understand how it happened, and I would like to understand what we are going to do to ensure it does not happen again. The security firm's director said Officer Cullen has been removed from hospital assignments pending a review. Dr. Ferris said that is a personnel matter for your firm. What I am asking about is protocol. What in your firm's protocol allowed an officer to enter a restricted clinical area without authorization and without first consulting the nursing supervisor? The director said we are reviewing the protocol. She said I need that review in writing. Within 5 days. It was done. Dennis Cullen's assignment to Callaway Regional was terminated. He was reassigned to commercial property work at a different contract site. The security firm issued a revised protocol for hospital investigations that required nursing supervisor consultation before any contact with clinical staff in restricted areas. Karen Vogt, his shift supervisor, received a formal written notice about the inadequacy of the briefing she had provided when assigning the case. The notice was not a termination. It was an instruction to develop a more specific assignment protocol for hospital site investigations in writing within 30 days. She did this. She was thorough. The protocol she wrote was specific enough that a subsequent officer assigned to a similar case would know before leaving the security office exactly how to conduct the first contact. The hospital's patient safety committee reviewed the incident at their monthly meeting. They added a specific requirement to their contractor oversight policies. Any security investigation involving clinical staff must follow a documented consultation process before making contact. Harold Price brought Gloria a copy of the committee's findings 2 days after the incident. She read it at the nursing station during her lunch break, which she took at 12:45, because she had been running 15 minutes behind since the second distribution. She read all 6 pages. She read the section on Cullen's actions, and the section on the security firm's protocol failures, and the section on what the hospital's own contractor oversight policies had not previously required and were now being updated to require. She read the paragraph that described the timeline of the morning the medication room encounter at 7:18, the code blue at 7:41, the successful outcome at 7:52. 14 minutes from the encounter to the code. 11 minutes of the code. 25 minutes of a morning in which she had been questioned in her own workplace and then required to be everything she had spent 31 years becoming, without a transition, without a moment to reset. She had been both things. That was the work. The work did not wait. She said they named the code. Harold said the code is relevant. You ran a code blue 11 minutes after that encounter. She said I would have run it the same way either way. He said I know you would have. That's the point. She said what's the point? He said the point is that you ran a code blue 11 minutes after a plainclothes officer walked into your medication room and questioned your right to be there. And you ran it correctly, and the patient is in step down. And the committee wants that in the record not because it's surprising no one who knows you is surprised, but because the record should show what you were managing and what you did with it. She was quiet for a moment. She said Adese is doing well. He said she's being moved to step down today. Gloria folded the report. She said good. Adese's husband arrived at 4:30, 2 hours after his wife had been moved to step down. His name was Emeka, and he was 57, and he had driven from his office 30 minutes away after receiving the call from the step-down unit, and had been moving at the particular speed of a man who is trying to look composed while everything in him is moving faster than composed. He stopped at the nursing station. He said my wife was moved to step down. They told me she coded this morning. The nurse at the station said, let me get Nurse Ashford. Gloria came to the station. She said, Mr. Osei. He said they told me there was a code at 7:41. She said yes. He said, is she? She said she's stable. The step-down team is monitoring her closely. What happened this morning was a cardiac event and we responded to it and she responded to us. She is in the right place now. He said she was scared this morning. She called me before her shift started. She said she had a feeling. Gloria said, did she tell you what the feeling was? He said she didn't know, just a feeling. Gloria said people know things sometimes before the measurements tell us. That's not a medical claim. It's just something I've seen a lot over 31 years. He said she told me once that she trusted this hospital because a nurse on her last admission was very good. She said the nurse knew her name from the chart but talked to her like she knew her. Gloria said, was that on the 3rd floor? He said, I think so. She said it was a year ago after her first procedure. Gloria said, I do remember her. He said, I want to thank you for this morning. She said she did most of the work this morning. We just helped. He looked at her. She said, room 318 and step down. Go be with her. He went. Her daughter Kezia called that evening. Kezia had heard from a colleague in the hospital network that something had happened at Callaway Regional. She had called to ask. Gloria told her factually in the same sparse language she had used in her written report. Kezia was quiet for a moment. She said, Mom, Gloria said I ran a code at 741. Adaya's OC 53. She's in step down now. Kezia said I heard. Gloria said that was the morning. Kezia said, what about the other part? Gloria said the other part is documented. The protocol has been corrected. The discrepancy was a paperwork error. Kezia said, and you? Gloria said, I am fine. Kezia said, Mom. Gloria said I have been doing this for 31 years. I know what I am. I know what I did this morning. I know who Adeze Ose is going to go home to. Kezia said, I know. Gloria said, that's the morning. Kezia said, will you call me tomorrow? Gloria said, I will. There was a pause on the line. Kezia said, do you ever think about stopping? Gloria said, stopping what? She said, going in, doing the work, after days like this. Gloria said, no. Kezia said, I do sometimes. After a bad shift. I think, what am I doing? Why am I here? Gloria said, and then what? Kezia said, and then I remember why. But I have to remind myself. Gloria said, that's okay. The reminding is part of it. Kezia said, does it get easier to remember? Gloria said it gets different. Not easier exactly. More natural. Like you stop needing to find the reason because the reason has become part of you. She said 31 years will do that. Kezia said I have 29 more years then. Gloria said you do, and every one of them will give you something. She said call me tomorrow. Kezia said I will. She went to bed. She woke the next morning. Before she got up, she lay in the dark for a few minutes in the specific kind of stillness that she had learned over many years to use as an inventory. She thought about Adeze Ose and Step Down. She thought about Bernard Watts and his notepad. She thought about the medication room and what had happened there, and what she had done and what Harold had done and what the investigation was now doing. She thought about Dennis Cullen. She had been asked in the committee's written follow-up whether she wanted the firm to take any additional action regarding Cullen specifically. She had said the action I want is the protocol. I want the next officer who gets assigned to a hospital investigation to know how to do it correctly before they walk onto the floor. That is the action that matters. The committee had noted this. They had thanked her for the clarity. She had not said this because she was not angry. She was angry. She had been angry with a controlled, focused anger that did not interfere with the work, but did not disappear either since the moment Cullen had moved between her and the phone. She had been angry during the code, not at Cullen. The code did not have room for that, but at the situation, at the sequence of decisions by multiple people that had placed her in a medication room during a distribution with an uncredentialed man questioning her presence in her own workplace. She was still angry. She was also clear. She knew the difference between anger that was useful, anger that sharpened attention, that clarified what needed to change, that produced the specific and factual and actionable report she had written at noon, and anger that was not, that would circle back on itself and exhaust her without changing anything. She had learned to use the first kind and set down the second. She set it down. She drove to Callaway Regional. She parked in the same spot she had been parking in for 11 years on the east side of the lot, where the tree gave shade in the summer, and where she had learned after 11 years that the meter was always good until 9:30. She sat in the car for 3 minutes. She had developed this habit sometime in her 15th year of nursing, not as a formal practice, but as something she had noticed herself doing after particularly difficult days, and had eventually formalized because the 3 minutes had turned out to be useful. Not restorative exactly. 3 minutes was not long enough for restoration, but transitional. A seam between the day before and the day beginning. A moment in which she was neither the nurse from yesterday nor the nurse from today, but simply Gloria Ashford, 56, in a car in a parking lot, watching the morning light come across the hospital's east face. She thought about nothing specific. She let the morning be what it was. After 3 minutes, she got out of the car. She walked to the 3rd floor. She stopped at the nursing station and checked the overnight notes. 2 new admissions. 1 patient had been moved to step down. The patients who remained from yesterday were stable, one of them showing the specific kind of overnight improvement that the morning team would find encouraging. She read the notes carefully. She made her own marginal notations. She composed in the first 3 minutes at the station the specific picture of the floor she would need to move through the morning. She put on her badge. She went to the medication room. She opened the log. She looked at the 12 names on the morning's distribution list. Some of them she knew from previous days. Some were new admissions from overnight, their names and histories still being assembled in her mind from the notes she had read. Each one was a person who was going to need this morning the specific quality of attention that she had been providing for 31 years. Not just the medication, not just the correct dosage at the correct time, but the presence of someone who knew what to do and who was not afraid, and who saw them as a person rather than as a condition. She was ready to provide it. She began the 7:30 distribution. The floor was the same floor it had been the day before and the day before that and the 22 years before that. The patients were different. They were always different. That was the nature of the work. But the work was the same work. The medication, the vitals, the specific quality of attention that tells a person, you are there and you are not afraid and you have done this before and you know what to do. Room 3. 1-2 had a new patient this morning. The woman who had been in room 312 yesterday was in step down now. She was doing well. Gloria completed the first distribution. She went to the first patient on her list. He was an 81-year-old man named William Okafor, who had been admitted the previous evening, and who was frightened in the quiet, still way of an elderly person who is not accustomed to being in a hospital, and who does not want to admit how frightened he is. She checked his vitals. She sat down briefly in the chair beside his bed. She said, "Good morning. My name is Gloria. I'm going to be your nurse today." He looked at her. He said, "You seem like you know what you're doing." She said, "I've been doing it for 31 years. He said, "That's a long time." She said, "Yes, it is. How are you feeling?" He told her. He told her about the discomfort in his shoulder from the IV site. He told her about the noise from the corridor that had woken him at 2 a.m. He told her about his wife at home, who was 78, and who was managing, but who he worried about when he was away. She listened to all of it. She noted the IV site. She noted the corridor noise. She noted the wife wrote the name in her margin note and said, "We can have someone call her this morning." Sometimes families just need to hear a voice from the floor. He said she'd like that. She worries. She made the call herself before rounds were complete from the nursing station. A woman named Vera Okafor answered on the first ring and said, "Is he all right?" Gloria said, "He's doing well. He asked me to call because he knows you worry." Vera said, 81 years old and still taking care of me. Gloria said, "I'll keep you updated. You can reach the floor directly." She attended. She continued her round. She checked the IV site in room 313 before she left that half of the floor as she had noted she would. The placement was fine. She had been right to check. She confirmed with the daytime aide that Mrs. Vera Okafor would receive a call before 11. The aide made the note. The call was made. The floor was the same floor it had been yesterday and the day before and for 22 years. The patients changed. The work did not. The attention did not. The standard of what she brought into each room did not change based on what had happened outside the room, because the patient in the room did not have the luxury of her having an off day, and she had understood this since her first year of nursing, and she had not lost the understanding in 31 years, and she did not intend to lose it now. Bernard Watts went home on Friday. He had filled 3 pages of the notepad. He shook her hand at the door of his room and said, "You're very good at this." She said, "So are you." He said, "I just laid in a bed." She said, "You asked the right questions. You did the exercises. You are the hospital food without too much complaint. That's the patient's part of it." He said, "I never thought about it that way." She said, "Take care of yourself." Adeyeza Osei was discharged the following Wednesday. Her husband left a card at the nursing station addressed to Gloria Ashford, charge nurse, 3rd floor. It said she told me she felt safe because she knew someone on this floor was paying attention. She was right. Thank you. Gloria read it during her afternoon break. She folded it and put it in her bag. She went back to the floor. She had been doing it for 31 years. There was a note on her desk when she finished rounds. It was from the resident, the young man who had been in the code, who had held the IV access, who had noticed the readout change at minute 7. He had left it at the nursing station before the end of his shift. It said, "Thank you for what you said in the hallway. I'm going to keep thinking about the difference between calm and focused for a long time. I want to be the kind of doctor who thinks about that." She read it. She put it in her bag with Adeyeza Osei's card. She went back to the floor. She intended to keep going. Subscribe our channel. We tell the stories of the people who know what to do when it matters.